So Scott is coming. You gonna say something?
No, go to it.
Scott is not coming. Brian is not coming, and Ahrar is not coming.
No.
Come on.
Just us. We're ready.
Okay. So good afternoon. I hope you all enjoyed lunch and you enjoyed this morning the session. We shift gears now and discuss cases with advanced disease. So that's metastatic. So first, I'd like to tell my colleagues here, the panelists, we heard from several of you to avoid using too many technical terms and medical terms or scientific terms, and try to be using more terms that patients and families can understand. So renal cell carcinoma is kidney cancer. Obviously, there are other types of kidney cancer. That's why we use the word renal cell, but that's the majority of kidney cancer. So without further delay, we'll go ahead and start with the first case. This is a 55-year-old male who presented with blood in the urine, and he has excellent performance status, functioning, performing activities of daily living without any restriction. No significant illness other than obviously the kidney cancer, but he has slight anemia. The hemoglobin, red blood count is a little low, 10.3, but the rest of the labs are normal. There is no evidence of metastatic disease by bone scan, by MRI of the brain. But he does have, as we will see later on the next slide, pulmonary nodules and a mass in the right kidney. So this is why he underwent a biopsy of this tumor in the right kidney, and it showed the most common type of kidney cancer, what we call or refer to as clear cell renal cell carcinoma, Fermin grade 3. As you heard from this morning, this is an aggressive tumor. And as you can see, obviously the mass is a large one, measuring approximately 14 centimeter this way, and about 9 centimeter this way. So fairly large tumor. Other views, you could see that he has, in addition to the mass here, the big kidney tumor, this is the right kidney here, what's left, what you see of it, and there is a enlargement of the right adrenal gland. There are two glands over each, one over each kidney, and there is another adrenal gland on this side, on the left side as well here. And you can see there are spots in the lungs, so he has evidence of metastatic disease to the adrenal glands and to the lungs. So what would you offer this patient? And question to my panelists, and we'll start with our surgeons here. Dr. Mateen, would you do upfront cytoreductive nephrectomy? And would you remove both adrenal glands? And if so, why? And if not, why not?
Yeah, I mean, and just to be clear, you know, we usually do these cases by discussing it with one another. I usually walk down his hallway and find him and talk, and so we don't make these decisions in a vacuum. You know, looking at him, he's having symptoms of hematuria, blood in the urine. The overwhelming majority of the cancer is in the kidney. And so I would consider actually doing removal of the kidney and the adrenal on that side. Whether you remove the cancer in the opposite adrenal or not gets to be a little complicated, because sometimes there are clinical trials that they can be eligible for after removal of the kidney, but not if they're on steroid replacement. If you remove both adrenal glands, the patient has to go on lifelong steroid replacement. And so it's just something to talk about. I think most clinical trials now don't exclude that factor. So it's just one of those things you want to think about, just so you don't, you know, just so you can set everything up for success. But it's a discussion that needs to be had whether or not you remove that or not. That would be my thinking, is just to do surgery first, at the very least remove kidney and the adrenal on that side. Consider the other side.
Dr. Karam, do you agree?
Yes, I would agree with Dr. Mateen, and like you said, we don't make these decisions in a vacuum. We always discuss among each other, just like we're talking now, in a less formal setting, but I would choose option number one after discussion with you, unless there is a clinical trial that he is eligible for and wants to enroll. Choice number one would be my recommendation.
Would you remove both adrenal glands or just the ipsilateral?
If the aim is to make him disease-free in the abdomen and retroperitoneum, and if it doesn't interfere with any planned clinical trials, I would try to render him disease-free in the abdomen.
So you would remove
both adrenal glands.
Both adrenal glands.
And the kidney and the lymph nodes as well.
Okay. Dr. Wood?
Yeah, the issue here is I would recommend upfront cytoreductive surgery, and the real issue about the adrenals, not only clinical trials, but if you take both adrenals and it takes IL-2 off the table. And this patient, young, excellent performance status, just metastatic disease to the lung and adrenal. If there is a candidate for IL-2, this would be one. So, by removing both adrenal glands, you would take that off the table for the patient, and I'd have that discussion with him. But I think at the end of the day, definitely cytoreductive nephrectomy, definitely removal of the right adrenal, and then a discussion about the left adrenal. And if the medical oncologist thinks that IL-2 might be a good choice for this patient, then I would leave that left adrenal.
Dr. Pillay, would you recommend upfront systemic therapy instead of surgery?
No, I agree with my colleagues. I think the challenge also for systemic therapy, you would commit this patient to a therapy that they might not need immediately. These are, we call synchronous metastasis, meaning the patient has newly diagnosed kidney cancer and also unfortunately has small lesion in the lungs and in the adrenal, but he might not need therapy right away. Different story probably for the immunotherapy, where we want to try to treat the patient when the tumor is relatively small. So I would say, I would agree, removing the kidney and assess the patient whether it would be candidate for high-dose interleukin-2.
Dr. Harrison, what do they do at Duke?
I totally agree. I mean, I think this is a great patient to get cytoreductive nephrectomy, and then the patient is young, sounds like is healthy, has only a few risk factors, and would otherwise be appropriate for high-dose interleukin-2. And so we'd really be thinking about that.
Okay. All right, so if now we did the surgery, we took the kidney out, and we took the right adrenal gland out. And as per the recommendations of our surgeons, we left the left adrenal gland in. Now, the patient recovers from surgery, and he's anxious to start systemic therapy. What would you pick from this menu? Dr. Pile?
Well, again, I think if the disease is only in the lungs and he has a really too little nodule, there is nothing wrong actually for the patient to wait, because we don't know how fast this tumor has been growing. If a patient is motivated, I would say, yes, I would offer high-dose interleukin-2. We have a trial of Roswell and Hopkins where we combine with entinostat. It's an agent that make IL-2 hopefully work better. But I would also discuss, even as young, just maybe do another scans in 2 or 3 months, get a sense how fast those lung nodules are growing. Because sometimes we do see that those nodules do not grow. And why commit the patient to a therapy that unlikely will cure his cancer, but it will definitely make him sick. So,
actually, I'm glad you brought that up because I was going to ask earlier. Before we had the TKIs, that was sort of standard practice. We used to do the surgery, and we'd send them to you guys, but then in about 30% of cases, you guys wouldn't treat. Partly because the therapies weren't really that effective. But I'm glad you brought that up. It seems like the threshold to want to treat is lower now, and so.
Yeah, I will not say it's lower, but I think it's. I think not because we have a therapy, we have to use it right away. And yeah. I think it's a discussion that we need to do it with the patients. And some patients are uncomfortable. I mean, I need to disclose, I'm here actually to learn today, not to talk about what I do, because I want to learn also from you, since you're patients, and it's important for us also to get some feedback on how we should discuss all these things with patients that actually involved in the care. So, I think it's an open question, especially when we don't know the natural history of this disease, and we know that sometimes kidney cancer grows very slowly. As you point out, most of the tumor was in the kidney, so, and it's really left a little bit left behind. So. There would nothing wrong to watch it.
Dr. Harrison, would you like to add? The patient still has pulmonary nodules 6 weeks post-op with repeat imaging studies. The left adrenal gland was left in place, so he has metastatic disease to the lungs and to the left adrenal gland. And the patient will do what you recommend. If you recommend, as Dr. Pile is recommending, since he is asymptomatic, to assess the behavior of this tumor, after a while, or would you say, let's go ahead, we have a window to cure you, let's try to start some systemic therapy now without delay, or would you observe for longer?
Well, I think, for the purposes of this, we're trying to be definitive. So to be definitive, I would, I don't disagree with what Dr. Pilley said, and I don't disagree that it would be okay to watch the patient. We have so many options nowadays. I don't know that you're going to lose a lot by monitoring for a little while and perhaps talking with the patient about their wishes more. But you also hate for a chance to miss a cure. And so what we're talking about when we're talking about high-dose interleukin-2 is we're talking about the only therapy that induces what we think are durable, complete responses. And so those are, it varies depending where you look, but maybe at 3 years, 5 to 8% of patients have a durable, complete response. Again, varies, and you hate to miss that. Now, I don't know that we would really miss that window if we waited for 3 months, so I can't really push back that hard. But this is the type of patient that I would be a little bit more directive in personally, at least in trying to get them to consider and understand high-dose interleukin-2 and understand what it could offer them, and if we don't offer it, to have a good reason why not.
Okay. Well, so the patient undergoes cytoreductive nephrectomy with ipsilateral adrenalectomy. The pathology is consistent with clear cell, firmly grade 4, T3A and 0M1, and he started on Sutent, the standard dose and schedule, and 3 months later, the patient has restaging, and it shows partial response in the lungs, no change in the left adrenal gland, and the therapy is continued. but it had to be reduced by 25% because of side effects, predominantly here hand-foot skin reaction. And 6 months later, there is evidence of progression in the lungs with new tumors, as well as increase in size of the existing tumors, and increase in the left adrenal gland, and a new solitary liver metastasis. Now, what would your option be now, Dr. Pillin? You have the option of serial metastasectomy.
Well, first of all, I would be curious of why IL-2 was not offered, or whether it was offered to this patient and the patient declined. Because as we know, unfortunately, high-dose interleukin-2, with all the caveat and limitation and toxicity, is still not offered to the majority of patients who are candidate for this approach. But, it looks like this patient is progressing with new lesions, so this is definitely warrants a change in plan. I think I found that the opportunity to increase the dose of sunitinib back to 50 intriguing. And why is that? We've been experiencing, and also other, that definitely there is a dose-dependent effect. What does it mean? The more drug we can give it to the patient, the better it is. But we started also looking at that in some patients who are able to tolerate sunitinib, at the time of progression, if we are able to dose escalate, to increase the dose, we do see responses. We have some very nice data also in animals where we observe the same things. We started with sunitinib. At the time of resistance, we increased the dose, we see response. But I think usually the approach, if a patient experiences severe toxicity at a certain dose of sunitinib, we tend not to go back on the full dose. So I would be reluctant probably to go back on higher dose of sunitinib in this patient, unless it's tolerating the 37.5 very well. And we know that as also, I know that you have a manuscript from your institution in terms of intrapatient dose escalation sunitinib. A different schedule of sunitinib might be helpful. So maybe this patient might still be able to go to 50, but 2 weeks on, 1 week off. This schedule probably is more tolerable for patients. And we can still achieve a higher level of this drug. So maybe consider also that. Long answer to a short question, but alternative, I would probably look for a different mechanism of action of the drug. So I'm not a big fan of sequencing this drug. They have the same mechanism. So probably I would go with the everolimus or clinical trials that include everolimus.
Okay, Dr. Harrison, since the patient did not get high-dose interleukin-2 upfront and received sunitinib instead, would you consider high-dose interleukin-2 now?
I would not consider high-dose interleukin-2 at this point. I think there's definitely limited data, but what data we have shows that the high-dose interleukin-2 is probably more toxic when it's given after these newer targeted therapies. So I know it has been done in some cases, but I would not recommend that.
Dr. Wood, any role for surgery here?
No, there's no role for surgery here. The disease is too extensive, and I think that my recommendation to this patient would be to do everolimus or a clinical trial. And I think that the teaching point here also is that the window of opportunity with high-dose IL-2 was when the patient first presented. It was the ideal candidate, but that bridge has been burned with getting the targeted therapy.
Okay, so we move on to another case. This is a 55-year-old male with history of kidney cancer. In the past, he had a right radical nephrectomy with IVC thrombectomy more than a decade ago. And the pathology as shown, clear cell, T3B, N0M0, Furman grade 3. And he underwent routine surveillance studies. Last was 2 years ago, which was negative. He has no symptoms except for history of prostatic hypertrophy and kidney stones. Now, by CAT scan of the chest, he has multiple small pulmonary nodules, but no other disease elsewhere. What would you offer this patient? And You see here also, Chris?
So this is many patients ask when they're getting surveilled in the clinic, when can we stop this? When can I stop getting CAT scans? Now here's a guy that's 14 years out from surgery and now has a new disease in his left adrenal gland. The other key point here, and Nizar, maybe you can point it out, is that when they did the right radical nephrectomy, they left the right adrenal gland, which is important because, again, putting someone on adrenal replacement therapy for the rest of their life is not a very, can you point out the right adrenal? Putting, there's the left, but you can see on that picture right there? Down. The right adrenal gland is in there. But, making someone adrenal insufficient and having to take adrenal replacement therapy for the rest of their life is not very appealing. So we have a solitary metastasis to the adrenal, no other evidence of metastatic disease. In my mind, this patient would best be served by a metastasectomy, where we would go in and remove that mass with the associated left adrenal, and then observe afterward.
What about the few pulmonary nodules? Sub-centimeter?
Yeah, I mean, that's the issue. They're indeterminate. They could represent metastatic disease, but I would argue that if we sit and wait to see if they developed, then they will be metastatic disease. And so, we'd have to counsel the patient that you do have these indeterminate nodules in the lung and that those nodules could represent metastatic disease and you might require additional systemic therapy in the future. But, 55 years old, I would say, swing for the fences.
So we'll move on to another case. This is a 62-year-old female who presented with blood in the urine. Initially, she was treated for a bladder infection, but the bleeding persisted. So she was evaluated further and was found to have kidney cancer. We'll look at the images in a minute. But her past history, she has reflux symptoms, diabetes, and she is in excellent health otherwise. She has no symptoms related to the cancer. But the laboratory investigation shows this is a blood test called lactate dehydrogenase. When it's elevated, it indicates high tumor burden. The upper limit of normal in our lab is 618, so this is more than twice higher than the upper limit of normal. This is a function of the filtration of the kidney. It's called estimated GFR, glomerular filtration rate. As we heard this morning, the normal is 60 and above. This is clearly a reduced filtration rate, so she has compromised kidney function, but the rest of her labs are within normal limits, and there is no evidence of metastatic disease to bone or brain by these imaging studies. And here is her scan, and you could see a very large mass arising from the right kidney. And what would you do, Dr. Karam?
The mass looks unusual in its configuration, and you could see part of the right kidney. It looks like it's devascularized almost, the lower part, and it's replacing the actual kidney itself. And there's also some enlarged nodes behind the vena cava and between the vena cava and the aorta. And I can't tell what's going on with the adrenal yet, but it is a bit unusual, and this is someone I would probably recommend a biopsy before we proceed with any further therapies.
Dr. Mateen, you recommend there is no metastatic disease?
Yeah, so, I think the biopsies is an intriguing option, and I think reasonable, for the reasons Dr. Karam mentions. The thing is, you think about doing surgery, and, you're going to remove all visible disease, so why not? The problem is when it's in the lymph nodes, if it's clear cell, it's not really going to be curative. If it's something else, or if it has sarcomatoid, then even less so. I don't want to get overly technical in terms of all those different things. But, I actually think biopsy is pretty reasonable.
Okay, well, this is her CAT scan of the chest. And she has here enlarged lymph nodes.
Oh, she does have metastatic disease.
In the chest, yes.
Okay.
So there are enlarged lymph nodes in the chest.
Yeah.
And again, we see the mass in the right kidney. Now, with this information, large mass in the right kidney, enlarged lymph nodes near the right kidney, and these lymph nodes in the chest. How would your management change? Dr. Mateen?
I'd feel even better about doing a biopsy.
Okay.
Yeah.
Dr. Wood, you agree? Or would you go straight to surgery?
No, I don't agree. I think that, again, the vast majority of this patient's disease is in her abdomen and is surgically resectable, albeit, would be a big surgery. She has an excellent performance status. There's really no contraindications to doing surgery. And so I would go with a right radical nephrectomy and resect the nodal disease that's present in the retroperitoneum, and then allow her to recover and reassess, and then decide on systemic therapy based on the histology of the primary tumor.
Okay, we'll hear it from the medical oncologist, Dr. Pillay. Would you do a biopsy as recommended by Dr. Mateen and Dr. Karam? And then how would that change your approach?
I don't think it's right or wrong, but I would probably go with Dr. Wood to do the surgery. I don't see. I mean, my concern always is whether this is a urothelial carcinoma or other more rare type of kidney cancer. But primarily the tumor is in the kidney, and this patient is relatively symptomatic. I would take the kidney out.
Dr. Harrison, you agree? Surgery first?
Yeah, I agree. I mean, there's always the concern it's some unusual histology, but I agree with the cytoreductive.
All right, so she underwent a right radical nephrectomy and resection of all the lymph nodes that are visible at the time of surgery, the pathology consistent with what you suspected, a rare kidney cancer. That's called translocation, carcinoma of the kidney. We refer to it as XP11.2. And, we know she has metastatic disease. That's the M1. The nodes make her N1 and the T3A. 17 of 18 lymph nodes removed were positive for metastasis, tumor involvement with extranodal extension. Now, what do you recommend, Dr. Pillay? You suspected she may have rare tumor. Would your systemic therapy now be influenced by the pathology?
Nazar, could you just explain the importance of, or what the significance of extranodal extension is for the patient?
Yeah, extranodal extension of lymph nodes is carries worse prognosis than if the nodes are still confined. So even though she had a resection of all the lymph nodes, that carries a worse prognosis. Dr. Pillay, the pathology now indicating this rare tumor type, does that influence your selection of systemic therapy?
Well, this is a challenging case because this is a really very rare kidney cancer, and we really don't know what's the best option for the patient. Of course, surgery is probably the best option, but it hasn't really solved the issue here. There are some, I believe, some cases reported about mTOR inhibitors in this kidney cancer type, but I would, because we don't know how to treat it, I'm a little bit positive. Usually these are younger patients. She's 62. Usually we do see this in younger patients, and more visceral metastasis than lymph node metastasis, but it is what it is. So I would still probably treat it with the drug that we have for advanced kidney cancer. Chemotherapy sometimes is offered in this case, but unless the disease is growing very rapidly and it has with involvement in the liver, the lungs, I would treat it with standard drugs.
Dr. Harrison, is there a role for IL-2 here in this lady with this tumor type?
I think it's unknown, but I doubt I wouldn't use IL-2.
Yeah. So as the panelist mentioned, this is a rare kidney tumor, but now it's estimated that 1% of adults with renal cell carcinoma have this type. So when you do what we call FISH on these tumors, you diagnose the translocation in 1%. So it's still rare. 1% is rare. Interleukin-2 is not recommended for patients with non-clear cell types, but only for the clear cells. So I agree. I think high-dose interleukin-2 is not an option here. And the prognosis of these tumors, if they're older, and again, Dr. Pillay made the point, that these are usually seen in pediatric ages, adolescents, and young adults, and rarely in older people. They do present with bulky disease and lymph node metastasis, and they are treated as we treat other types, preferably on a clinical trial. And we have a clinical trial at MD Anderson for non-clear cell, as well as the Duke group is leading a study for these patients. They're calling it the ASPEN trial, and it's looking at treating those patients into two groups, one group with everolimus, an mTOR inhibitor, and one group with sunitinib. And we have the same trial. We call it ESPN trial, and it's everolimus versus sunitinib, again, for these patients with these rare tumors.
Dr. Tanier, if I was able to convince you and have a biopsy done and show translocation, what would be the recommendation at the time? Would you...
Surgery.
Still surgery?
Yes.
So let me just stir the pot a little bit. So what on the biopsy would tell you not to do surgery?
If it's sarcomatoid or if it's translocation?
He's saying do surgery with translocation.
I know, but I might not want to.
Well, I think
Then he said, just send it to me.
And I think,
Because the question is,
well,
are
this-
we benefiting the patient by doing surgery with this type of aggressive histology? And I don't know if we know the answer to that at this point.
Well, that's the challenge, is that this is such a rare histology that, we can't look at the last 500 patients that had translocation tumor because we don't have 500 patients. And, I think in the absence of, effective systemic therapy that, radical tumor debulking, represents this patient's best chance at having some sort of prolongation of life.
I think if you extrapolate from the pediatric literature, translocation in young adults or pediatrics, children, it's always the approach has been, before all these targeted therapies came to existence, was to do multiple resections. Resection, obviously nephrectomy, and then removing lymph nodes, and continuing to go on and doing successive resections. And these patients live many years, and the prognosis is better when you're able to perform surgery. So in this, in her case, it is, she's lucky, I believe, that she presented with resectable disease at the time of initial diagnosis, that she's able to get the bulk of her disease out. So I think we can move on to the next patient. This is a 59-year-old male who presented with left varicocele. He also had cough for 6 months, fatigue, and occasional fever and night sweats. And he felt a mass in the left side of his abdomen. And as we said, he presented with left varicocele. The labs were normal except for a male. He was slightly anemic, and the CAT scan on the chest showed metastatic disease. Here is the two views of his left renal mass, and you could see that it's a large mass arising from the left kidney, and I believe there is a compression here of the left renal vein. You see another view here. Dr. Wood, would you like to comment on left varicocele, the significance of this in a middle-aged or an elderly male?
Yeah. If a man during self-examination or by examination from their physician that there's a new varicocele, abdominal imaging is indicated because it indicates the left renal, or sorry, the left gonadal vein or left testicular vein comes off of the left renal vein, and varicocele means that there's back pressure that's filling up that vein and causing it to distend. And so it's a sign of a potential intra-abdominal pathology. So they should have abdominal imaging if they feel or identify a new varicocele. And in terms of this patient, how I would manage no metastatic disease, I would do a radical nephrectomy. I would probably do it through an open approach. And the reasoning for that is, number one, the tumor is so huge that by the time you make the incision to take it out after doing it laparoscopically, you made the incision that you would do it open through. But I'd also want to make sure that I do an adequate node dissection on this patient.
Dr. Batin, is there a size cutoff where you would not recommend laparoscopic robotic approach?
It varies a little bit on the configuration. Once you get to above 10, 11, 12 centimeters, the benefit goes down pretty quickly, like Chris said. So, and some of it just depends on how it's configured and how bulky it looks. but roughly about 12 is definitely the upper limit of when you lose the benefit, and sometimes even as less as 10.
Okay.
The only other point I'd make on this case is that the audience might be saying, well, why don't you give them some of that medicine that you gave those patients this morning to shrink it? And the answer is, again, that's in the context of a clinical trial. That's not standard of care. And, until we better iron out, how well these agents work, when is the most appropriate time to use them, upfront surgery still remains the standard of care.
So you would do a left nephrectomy here. Would you do an adrenal gland sparing, or you take the left adrenal gland?
Well, so you can see in the picture, and Nazar, if you could point out with the arrow, the left adrenal gland phenotypically is normal on the scan. I couldn't argue against taking out that adrenal, but with locally advanced disease, particularly since on the left side, the adrenal vein empties into the left renal vein, you actually have to go out of your way to try and save the adrenal, as opposed to on the right side where you have to, where the venous drainage is right into the vena cava. So I probably would take the adrenal gland with this, just because of the locally advanced nature of the tumor.
Okay. All right. So the patient underwent a left radical nephrectomy with resection of the visible lymph nodes, and the adrenal gland was removed with the kidney. The pathology, as you see here, clear cell kidney cancer, firmiculi grade 2, T3A, and 0M0. The nodes were all negative. Now, what would you offer this patient, Dr. Harrison? Would you offer the patient any adjuvant therapy?
So as we discussed this morning, this is another case of a patient who's at high risk for recurrence. However, adjuvant therapy is not standard of care off of a trial, so I would try to talk to the patient about possibly enrolling in an adjuvant clinical trial.
So, and we discussed this morning about, the surveillance studies, the interval. How often do we do scans or imaging studies? Do we do an ultrasound, as we discussed in Europe? That's what they're doing. Or do we use an MRI, or we use a CAT scan? And how often we do a CAT scan of the chest, or we just do a plain chest X-ray? So the patient was followed with serial imaging. He was without evidence of disease. That's the NED. No evidence of disease until 22 months after surgery, and he presented with, what you see here, a tiny pulmonary nodule. You see it here. And 28 months later, after surgery, he has these few pulmonary nodules, sub-centimeter in size, in the left lung. Dr. Pile, what would you do? Would you offer him systemic therapy, metastasectomy? You continue to follow. The patient is completely asymptomatic. He is healthy otherwise, except for essential hypertension that's well controlled with blood pressure medicine.
Yeah, this would be a compelling case to consider removal of the lung nodules, to send it to thoracic surgery, because it took 2 years to show up, this solitary lesion. So if it's the only spot, maybe it's not, but I think with 2 years interval, you can make the case. So I think definitely I would discuss with the patient the option for surgery.
Dr. Harrison, would you recommend systemic therapy?
No, I would not, and I think this is a patient where maybe we could avoid the chronic toxicity of targeted therapy. The patient has some features that Roberto pointed out. So 2 years since surgery, it's a solitary metastasis in the lung, so there's some retrospective studies showing those may be factors, indicating that they could benefit from surgery. So I would recommend the surgery and try to avoid systemic therapy.
No high dose IL-2?
No,
okay.
Not at this point.
So the patient was sent to thoracic surgery and had a left thoracotomy and resection of these pulmonary nodules. That's what this medical term means, metastasectomy. A total of 6 nodules were removed from the left lung, 2 of which had metastasis, so there were tumors, 2 out of the 6, but the margins were clear. Now he is, again, without evidence of disease. Is there anything we will do, Dr. Pile, now? Would you do anything after the complete resection?
So the standard of care is observation. So just have the patient recover from surgery and watch him.
Okay.
There is an ongoing trial I think it's already open through ECOG, where they're going to offer, I think it's going to be randomized placebo versus pazopanib. So what's the role of this agent that block the blood supply to prevent further metastasis? So I think if that study is available to the patient, I would refer to that trial, otherwise observation.
Okay. So 8 months after the resection of these lung nodules, you could see he was being followed, but now you can see there's some nodules appearing again. You see here. So there are small lung nodules appearing in both lungs now. He has bilateral lung nodules. This is 11 months now after he had resection of these lung nodules from the left lung. What do you recommend, Dr. Harrison? Would you continue to observe? He's asymptomatic. Would you send him for systemic therapy, or would you do another metastatectomy, this time bilateral lung nodules, bilateral thoracotomies?
Yeah, I mean, I think the fact that the time frame from his last metastasectomy being so short and the bilateral nodules, that kind of rules out another metastasectomy, or in other words, resecting nodules from both sides. So I think that this patient is going to need systemic therapy. And then, this is similar to one of the cases we discussed prior. Is it wrong to maybe watch for a couple of months and see what happens? It's probably not. But on the other hand, we hate to miss a window. And this is another patient where the patient is young. I would be thinking about high-dose interleukin-2 based on the patient's wishes. And, of course, there would be other systemic therapy options, too.
Dr. Pillay, you agree?
Yeah, I agree. I'm always reluctant to start treatment if the tumor is very small. So, this patient would not qualify probably for a clinical trials because we need to have a certain dimension, at least 1 centimeter in dimension of these nodules. So if it doesn't fit the criteria for a clinical trial, probably I would still not start systemic therapy. But I would agree with Dr. Harrison that eventually he will need it.
Dr. Wood?
I mean, call me surgeon mentality, but I mean, I think that this guy would be perfect for high-dose IL-2, and that's where I'd refer him. I think, it's clear he's got metastatic progression. He's got small volume disease. He's in excellent health. He's got a zero performance status. This is the classic candidate for high-dose IL-2. Admittedly, there's toxicity, but if he's going to be cured, that's his only shot. And if it were me or my father, that's what I would do.
So the patient we discussed.
I would do the same, Dr. Wood, but I was, waiting sometimes, even for immunotherapy at that stage, probably is not going to be harmful. I think the patient eventually will need to have a systemic therapy, but I'm a strong believer high-dose interleukin-2, and that's why we have also a clinical trial with IL-2 and tinostat. But, again, unfortunately, the complete response rate is still very low, and so it's a lot of toxicity. And sometimes the patient is a patient that go and get it, type of mentality, you jump on the treatment. Another patient might be a little bit more laid back, but at the end, I think the IL-2, if it's a candidate, I think is the best option for him right now.
And I think for the people in the audience, this is a decision that's always made, with the physician and the patient and the family. So obviously, we present all the options: high-dose interleukin-2, target therapy, on protocol, off protocol. We discuss all the side effects, and I think ultimately the patient and the family will come together with the physician and decide what they want, how aggressive they want. Are they willing to go through the risks of high-dose IL-2? And I think it's a personal decision. I think we discussed these options with the patient, and jointly we made the decision to treat him with high-dose IL-2, and that's what he's getting next week. All right, we'll move on to another case. This is a 66-year-old male who presented with hemoptysis. He coughed up some blood while traveling, and past history, he has high blood pressure, on therapy controlled, high cholesterol, and he was evaluated because of the hemoptysis, and they did a CAT scan of the chest. They were concerned more about his lungs because of this coughing up of blood. And the lungs were okay. There was nothing obvious in the chest by CAT scan, but incidentally, they discovered a mass in the left kidney and a benign-looking cyst in the right kidney. And again, on examination, similar to the patient we presented before, he had the left varicocele. Again, to drive the point that a left varicocele in a middle-aged and an elderly male should trigger a further evaluation. It should not be just left alone. Patient should be evaluated for something happening in the area where the left kidney is. And so this should be a bell for the patient as well as for a primary physician and urologist. The labs were all normal, and he had this mass in the left kidney here, but no metastatic disease. Dr. Karam, how would you approach this patient? No metastasis.
So the chest
and he has
is clear?
this mass in the left kidney.
So the chest is clear?
Yes.
No, we don't know why he was
no
coughing
metastasis.
blood.
No metastasis.
And that's all the films you're going to show me, right?
Yes.
Okay. So
no
I
hidden
would-
agenda.
So for this patient, I would do a left radical nephrectomy and node dissection. You could see some probably enlarged lymph nodes there. Yep, that's what I would do.
Laparoscopic open.
I would do it open myself just because of the nose being in a tricky location.
Would you also take the left adrenal gland with the kidney? With the left
I don't
kidney?
know because I can't see it on the film. So
But
if
let's say it's not enlarged. Do you take it out?
If it's normal, I would not remove it because the chance of metastasizing to the adrenal, it could happen to both sides. So direct extension of the tumor to the adrenal gland, you can usually see it on the CT scan or during surgery. And what we're worried about is metastases from the kidney to the adrenal gland, which could happen both to the left or to the right side in, I think, almost equal frequency. So if it looks normal during surgery and on imaging, even on the left, I would personally keep it.
Okay, Dr. Mati, how would you approach this patient?
I agree completely. I'd do the same thing. I would open radical lymph node dissection, preserve the adrenal.
Okay, Dr. Wood, yeah, differ or?
I mean, I would probably remove the adrenal. It's just my sort of policy on locally advanced disease, particularly again on the left-hand side where they share the same venous drainage. Certainly it could show up in the right adrenal as well. But I think in these more locally advanced tumors where the risk of metastasis is higher, that, I would probably go ahead and remove the adrenal. I would do it open. I would do a lymph node dissection.
Okay.
It is interesting, though, in a sense. I mean, if you have a lot more cases, we don't have to spend a lot of time with this, but we spent a lot of time talking about neoadjuvant therapy in the first part. And, in a case like this, when there's so much disease in the lymph nodes, and those are truly positive, they're not reactionary.
Where are you guys seeing lymph nodes?
I'm assuming those are nodes, unless they're big veins.
Unless this
on
is
the other
the
side,
gonadal vein or
below
what?
the aorta, on the other panel.
That's bowel, isn't it?
No, the other panel.
Behind the aorta?
Where?
Yeah.
That's bowel. It's contrast.
This is bowel here.
Behind the aorta?
Aorta, IVC.
And
Bowel.
bowel,
Yeah, but between the
Behind the
spine
aorta?
and the aorta.
It's not lymph nodes.
This?
Yeah.
well, it's
Sorry,
not
I'll
bowel.
show you guys how to read this later.
It's not bowel, unless,
No, the bowel
unless this is
doesn't
the
live there.
gonadal.
Those are not lymph
These
nodes.
are opacified bowel loops.
Behind the aorta?
Behind the aorta?
That could be that's
This?
probably a retroaortic renal vein.
This
It's
here?
not a lymph node for sure.
Yeah,
Come on.
that's why more films, yeah. But
Yeah.
But I think
Killing me.
the CT is coloring your decision to do open because you want to remove the lymph nodes. But
If
you
these
could-
are
Well,
lymph
on the
nodes.
basis that we thought those were, because there should only be 2 circles above the spine, and there's 4, 5. So, right?
Well, here, the patient underwent, and it's interesting, you all decided to do open, and the patient did undergo, in fact, laparoscopic, not open, left radical nephrectomy, and sparing the left adrenal gland because this, it did not look enlarged by CAT scan or at the time of surgery by inspection. The lymph nodes were all negative. And here's the pathology, T3A, N0, no lymph node metastasis and no metastasis. So we discussed this morning. What will be the role of any therapy in the patient where you resect completely the disease, but he has local advanced disease? This is the T3A. So as we discussed, not to belabor the point too much, but off protocol, if there are no clinical trials available to the patient, or if the patient declines participation in the clinical trial, in this setting to prevent or reduce the probability of recurrence of the disease, of the cancer after surgery, you observe them. And, the frequency of scans, we discussed that this morning. If the patient is interested, very interested to participate in a clinical trial that offers adjuvant therapy, these adjuvant therapies are all with placebo control. I think this is important for the audience to really know that these trials have a placebo control. So the patient, it's double blind, the patient, as well as the team treating the patient, the physician and the nurse, do not know what the patient is actually taking. The patient could be taking a placebo or a drug. And it's given for a finite time. The majority of these adjuvant trials are 1 year. So we all agree if the patient is interested, enroll him in an adjuvant trial?
Yeah. Yes.
Yes. Yeah. So the patient was offered to enroll on a trial that's called the ASSURE trial. It's a 1 year of adjuvant therapy with one of two drugs versus placebo, sunitinib, sorafenib, or placebo for 1 year. And the patient didn't know what he was taking, and that he had toxicity that led to interruption of therapy, in fact, it took him, because of the interruption, 14 months instead of 1 year to finish the therapy. But he did finish it. He did receive the therapy, didn't know what he was getting. And 16 months later, after surgery, we have this scan here. Dr. Karam, would you like to comment on the scan? What do you see here? I mean, this is a benign right renal cyst for the audience. This is a benign. But is there anything that catches your attention? And are you worried about anything here?
Like in that adrenal you left behind?
There's a 1 centimeter left adrenal mass that looks suspicious for metastatic disease.
Okay.
That's presented 2.5 years after surgery.
Okay. Would you have done anything at this stage of the game here?
What's that?
Would you have done anything at this stage of the 16 months after surgery? Would you do anything?
I would have obtained imaging more frequently, maybe 6 months later rather than a year later.
Okay.
Because it looked suspicious at that time.
Okay.
And if it is something that can be biopsied, I would biopsy that too. But other than that, I think surgery would be what I would recommend if the patient has no metastatic disease.
Okay. Dr. Mateen, any?
Yeah, actually, I have a sneaking suspicion this is one of my patients. Looks very familiar. So, yeah, I would do a laparoscopic nephrectomy. I can't recall if we did a biopsy or not. I think it's reasonable, but the suspicion is pretty high there. What did I say? Adrenalectomy. What did I say?
Nephrectomy.
Oh, yeah, I forget. Yeah, adrenalectomy. And I think the images we were seeing before, I think the patient probably had a vein coursing back there, which is what threw Dr. Karam and I off. We were thinking they were looking like lymph nodes in that one slide. But either way.
Yeah, whatever.
Yeah.
Michael, Roberto, would anybody consider systemic therapy or left adrenalectomy?
Surgery.
Okay.
Surgery, yeah.
All right. So he had a biopsy first, and that confirmed that this is metastatic disease. There was no disease elsewhere, and he underwent unblinding of his therapy and that he received before for 1 year on that trial, and he was receiving sunitinib. And the side effects he experienced while receiving this drug were consistent with the toxicity of this agent. What would you offer now?
They said adrenalectomy.
Okay. He underwent a left adrenalectomy, negative margins, and the pathology is 1 centimeter metastatic RCC. Patient was observed after surgery. 3 years after metastasectomy, surveillance films show a lesion in the left 7th rib. Remainder of metastatic evaluation is negative. And here, further evaluation of this, on the bone scan, he has a hot spot here, and on the CAT scan, there is this tumor here that corresponds to this. So he has metastatic disease to that left seventh rib. Dr. Pile, what would you do?
I think I remember the case, but that I read the case. But I think in this case, really 3 years, single metastasis means in the rib. I would make sure that that's the only site. But I would send it for surgery again because it's been shown that maybe it's the best option this patient has. I have a few cases when I was at Hopkins that exactly the same. Even after therapy, that is a sanctuary in the bones and in the ribs. I just take the rib out and I ask the surgeon to take the rib out, and the patient did fine. So I would.
If there is disease elsewhere,
different story, but depends on where it is. But 3 years out, single met in the rib.
Could the medical oncologist comment on the value of PET scanning in this circumstance? Michael, go ahead.
Sure, yeah. There's limited data, and there is some data, but there's really not a good role for PET scan. Again, we talked in the earlier session that the most common PET scan used is FDG PET, and so really that's what I'm talking about. That's the labeled sugar. There are other types that might be more informative, but I would say at least if we're talking about the common type of PET FDG, it's probably not that useful. There's limited data that may be useful for following treatment response and advanced disease, but probably not for staging. So I wouldn't recommend that.
Well, I think you brought up an important issue. I mean, nuclear imaging, I think, is functional imaging is improving. There is this notion that FDG PET does not work in clear cells, although there are some experience from Memorial. We had a couple of trials at Hopkins with PET and kidney cancer. Every patient actually light up. So I would say probably if it's covered, in this case, maybe it would not a bad idea to do a PET. Okay. If it helps you, if that lesion lights up and nothing else lights up, yes. It might be negative. If the lesion is negative, of course, it's not going to help you out.
So what you're looking for, though, is other lesions, right? Yeah, just to be clear.
But if the PET is negative, completely negative, it doesn't help because you know that likely has disease in the rib.
Okay, so he underwent a left rib resection, and the pathology consistent with metastasis of the kidney cancer. Post-operatively, he had fluid buildup in the left chest, we call pleural effusion, and had a catheter to drain that effusion, the fluid. The fluid was sent for cytology, sent to the lab to test for malignant cells, and there were no malignant cells. So it was a reactive post-operative complication, and it's not malignant pleural effusion, so no cancer in the chest, other than the rib that was resected. He returns for repeat staging, and now the radiologist, a neuroradiologist looking at the scans, says, well, there looks like some spots in the pancreas, which in retrospect were there a year before on a prior CAT scan, but now are more visible, more obvious, that they are consistent with metastasis to the pancreas. But there's no disease elsewhere. Now, what would you do? What do you offer him, Dr. Pile?
Well, it's a challenging case because, it is not the usual patient with kidney cancer we see in the clinic. But, and of course, it would be compelling, intriguing to think about, another surgery. Of course, the timing of this new lesion is getting shorter and shorter. So you're wondering. And of course, when we do see disease in the pancreas, you're reluctant to send a patient for a Whipple procedure, for example, where is a pretty extensive surgery. So I would, I would discuss maybe with the surgical oncologist whether there is any role for removal of but depending how safe can be done the surgery and whether that truly is the only site.
Dr. Harrison, would you go with total pancreatectomy. He has multiple lesions in the pancreas. It's not an option for a laparoscopic resection of the tail of the pancreas. This is the whole pancreas, multiple lesions. Would you do total pancreatectomy or systemic therapy?
If the only option was total pancreatectomy, I would not do it. I would do systemic therapy.
Systemic therapy, okay. What systemic therapy?
So
Would you go back, let me ask the question in a different way. Would you go back to sunitinib, which he received years ago as adjuvant therapy? Would you go with a different tyrosine kinase inhibitor? Would you go with an mTOR inhibitor? Would you go with high-dose IL-2? Or would you, obviously there is always the option of a clinical trial. What would you do?
So in this patient, I'd probably think about axitinib. I think a clinical trial would be a good option too. Certainly sunitinib retreatment would be a good option. There's some limited data that we can, if we treat patients and they progress on sunitinib, which this is a little bit different of a scenario. But anyway, if they do progress, we can retreat them. There's the dose escalation evidence. But I would have considered this patient to have had a good run at sunitinib and then think about a more potent VEGF receptor TKI like axitinib in this case.
Dr. Wood, would you talk to your surgical oncologist colleagues for a total pancreatectomy?
I mean, to be honest, no. I think that this guy has definitely demonstrated that his disease is systemic. It's also very indolent, but it's systemic. And I think, it starts to get ridiculous when you're just doing serial sectioning of the patient to try and take the cancer out. I think he's proved to me that he has systemic disease. And I think that, the good news is that metastases to the pancreas usually behave very indolently. They're not very aggressive. They don't grow fast. So of all the patients that we've talked about today, this would be the guy that I actually would observe for a period of time for two reasons. Number one, because the pancreas mets usually don't grow at a very rapid rate. They're very indolent. But also look to see if he crops up somewhere else, to see if his disease shows up in another organ system, and then at that point, consider instituting therapy.
You talk like a medical oncologist now.
Actually,
I think I just consulted. But,
Dr. Karam?
I'm glad you brought that up because my thought, for some, and again, it's one of these things about kidney cancer we don't fully understand, and there's clearly a seed and soil phenomenon. The cancers that go to the pancreas tend to behave generally, much more favorably than, for example, those that go to the liver. So, it's not clear to me, why that happens, and smart people like Dr. Karam maybe can figure this out over the next few years. But yeah, I would observe, I think, for those reasons that were mentioned. He may do very well for a while without any therapy.
Dr. Karam, would you have done something different if you knew that the disease was in the pancreas? At the time the left seventh rib metastasis was discovered, would you have done the rib resection, or would you have treated him with systemic therapy then?
If I knew he has both rib and pancreas,
Yes.
I would probably treat him with systemic therapy at that time. If he has more than one focus, including bone, especially if it's not symptomatic.
Okay. I think we can stop here, take a break. You can stretch, and we'll reconvene here in 10 minutes. 10, 15 minutes.
say 2:35.
2:30, yeah.
Nice to see
Yeah.
you.
It was a compliment.
I know.
Good job.
So what I've heard is that people are getting a little bit of case fatigue. So maybe we'll just pause for a minute. And do people have questions that they want specifically answered? Aside, this isn't a mini clinic. We can't do individual consultations. But if you have some general questions that you'd like answered that we haven't touched on, by all means, ask. Use the microphone.
We have heard about disease of the body in several forms, except the heart stroke, and etc. Can cancer grow in the heart, or it has to be contributed from another organ to the heart, or can it develop in the heart?
Can cancer develop in the heart? Is that your question?
Yes, sir.
Yeah, there are primary tumors of the heart. They're extremely rare. It wouldn't be related to kidney cancer. It would be, probably a sarcoma because the heart is made of muscle. But tumors can occur primarily in the heart, but as I say, they're very, very, very rare.
So the most common tumors found in the heart are metastases to the heart, and the commonest one would be lung going to the heart, lung cancer. Melanoma, which is rarer than lung cancer and breast cancer, has high propensity to metastasize to the heart, melanoma. Kidney cancer, rarely. We've seen a few patients develop metastasis to the sac and sometimes in the heart muscle occasionally, but it's rare. It's one of the rarest sites. It's more common to go, as we discussed throughout the day, to lungs, lymph nodes, bone, liver, and brain, but much, much less frequently to go into the heart. Any other questions?
When you just mentioned something about the brain, how often does kidney cancer advance to the brain? Because that hasn't been mentioned on any of the case presentations, and there hasn't been a lot of stuff listed as far as liver disease, advanced liver disease to the, metastases. So
the question is about...
do you have some case presentations where you have some better metastases, shall we say, with more advancement, like to the brain? What are you going to do? What do you advise the patient to do?
Sure. I don't think we have any of the cases brain, but I think we certainly can, answer or discuss any particular situation, if there is one with a brain metastasis.
Well, I know when we get in support groups and everything,
Can you talk to the
and there
microphone?
is metastases from renal cancer to the brain.
Could you please go to the microphone?
This one's not working? Oh, I have to talk closer? I don't like these things. Okay. Okay, what I'm asking is, when you go online to the kidney cancer support groups, when you go to the other support groups and people there have metastases to the brain, very little is ever talked about. And of all of the presentations that you've had here, we're not addressing some of the rarer things. And I'm sure some of the things that we all worry about is, you hear the term scanxiety. Everybody loves to go for the CAT scans because what's the doctor going to tell me, And so how do I know when it's affecting my brain? What's going to happen to me? Which of these medications are going to work for me? Can you answer that?
Sure. These are good questions. I think the brain is not an uncommon site for it to go to the brain. As we were just saying earlier, it is not a very common site. So lungs, lymph nodes, adrenal glands, bone, liver. In this ranking order, brain will be the least it goes to. But you're right. There are complications or there are challenges when it goes to the brain. But I think the brain should not be looked at as it's a death sentence, because it is not. There are patients who develop metastasis to the brain who are treated. I mean, obviously it depends on whether we're dealing with one spot, 2, 3 spots, or 10, 15, 20 spots. I think obviously if there is that many, typically more than 5, the recommendation would be to, depending on the size and the location, to treat with radiation or surgery. If one is particularly large, causing symptoms, headache or dizziness, and it looks like on MRI or CAT scan is causing bleeding, is to resect it. And then the smaller ones being treated with gamma knife or stereotactic radiosurgery. Sometimes if there are many, but they're all small, or they're in particular locations where surgery would not be possible, then we do whole brain radiation if there are multiple. But systemic therapy, again, this is contrary to what some people think, that the medicine doesn't get to the brain. On the contrary, some of the medicines we use to treat the metastasis in the lungs, liver, bone, etc., does cross the blood-brain barrier. And we reported on patients, a series from MD Anderson, 7 patients that had disease in the brain, where we treated with Suited, and some of these patients responded. In fact, 2 of them responded completely without surgery, without radiation to the brain. But it has to be an individual case-by-case discussion. I'm not suggesting that every patient that has spread of the cancer to the brain to not get radiation or surgery. Obviously, you have to discuss this. This is a consultation that we have with the neurosurgeon, with the radiation doctor, and the medical oncologist. But it is not a death sentence. There are patients who are alive, doing well, even though they had metastasis to the brain. There are some patients who don't have metastasis to the brain, have metastasis just in the lungs, or just tumor in the kidney, but it's unresectable and continues to grow and invade surrounding structures, such as surrounding organs, where the prognosis is worse than if the patient had their kidney removed and now they have 1 or 2 or 3 spots in the brain. I have many patients who have brain metastasis who are alive and well for 2, 3, 4, and 5 years and beyond. So it's not a death sentence. There are treatment options, and it's an integration of local therapies with surgery in some patients where surgery helps, radiation with gamma knife or whole brain radiation, as well as systemic therapy with drugs. Now, in terms of how do you know, the only way to find out is doing an MRI of the brain. Now, the problem is recently has been insurance companies are pushing back. They're denying. Every time we put an MRI of the brain request, they say denied. Why are you ordering an MRI? And we tell them, well, the patient has cancer of the kidney and it's spread already to, say, lungs or other organs. We need to make sure it's not spread to the brain. We don't want to wait until the patient has seizures or is falling, ataxic, to then get the MRI of the brain. And sometimes when we talk peer-to-peer with the insurance companies and try to convince them, they see it and they say, okay, you can do the MRI of the brain. But, unfortunately, sometimes this is found or discovered when the patient develops a symptom or a sign. They may either have some abnormality, difficulty speaking, or double vision, or weakness in the arm or leg, or numbness, and then you get the MRI of the brain and you find there is tumor there. But whenever we find this in the brain, we treat it in consultation with the neurosurgeon and the radiation therapist and the medical oncologist.
Does one of you, she also asked about liver metastases. I wonder if either you or one of the other medical oncologists wants to talk about that and why we maybe haven't really covered that very much.
Roberto, you want to, or Michael, you want to?
Well, there is the notion that liver metastasis carries a prognosis, and probably that's true. There are, some papers on IL-2 and the patient that who have liver metastasis may respond less. But on the other hand, I have a patient who has only liver metastasis and maybe solitary liver metastasis, and is still doing okay on treatment. So I think the organ specificity tell us some about the biology of this cancer, but one thing we didn't discuss much about the tumor heterogeneity today. What does it mean? That even though we're talking about kidney cancer, but there have been some very elegant studies now showing that, we're dealing with several types of cancer within the kidney cancer. and maybe the disease goes to the liver is different from the disease that goes to the lungs, but not necessarily all the time. Unfortunately, we still don't have the barcode to characterize this tumor, when is the kidney, when is the bones, or when is the lymph nodes. But go back on the issue about brain metastasis. I totally agree with you, Nizar, about how we approach that. But and I think what the message I want to tell you, and Nizar was saying, is that our patient with the disease in the brain, they do much better than they used to be. And whether it's because we have a better gamma knife, more experienced radio neurosurgeons, or this therapy do help. But, even I agree, in my practice, I have several patients with history of brain metastasis, still alive years after. So I think, probably kidney cancer is more favorable disease than other type of cancer. We didn't touch much about the radiation. We don't have a radiation oncologist here, but there is some compelling role for radiation, even to treat localized kidney tumors. And probably the notion that kidney cancer is radio-resistant, probably that's not totally true.
I would like to ask a question here. Here at MD Anderson, do you use SIR spheres to treat the liver cancers? I know at Stanford they do, because liver is liver when it comes to SIR spheres. Do you use SIR spheres treatment here?
I think we have a surgeon.
It's an radiologist, the interventional radiologists that do it, because the medication comes from Australia.
Yeah, so
No, we're not using that, but we're using nanoparticles.
You're using the TheraSpheres?
No, they're using different chemicals, gold and others, with nanoparticles in the liver. One of the surgeons who does this is Dr. Stephen Curley, but he's a surgeon.
So I think maybe what she means, and I'm certainly not an expert on hepatocellular carcinoma or colorectal cancer, but there's chemoembolization that they're doing through interventional radiology, and I think maybe that's what you're talking about.
That's what I'm talking about, is the chemoembolization.
It's not, as far as I know, it's not used for kidney cancer that's metastasized.
Well, it's not FDA approved, but it is for colon cancer and breast cancer, and I just wondered if they've attempted to do it here for kidney cancer for tumors, massive tumors in the liver.
Yeah, so I guess my response to that is that even though in general it's a cancer that's in the liver, it still retains the characteristics of kidney cancer, which is notoriously resistant to standard regimens of chemotherapy. So I might be best being quiet now because I'm going outside my realm and letting my colleagues in medical oncology pick that up. But the biology of the colorectal cancers that go to the liver and the liver cancers is much different than a kidney cancer that goes. So unfortunately, because that therapy might work for that patient population, it does not translate to the same for kidney.
I have two questions, a little bit more general. One, if you could bring us up to date on if there is any progress on immunotherapy. He's smiling. And the second is the most recent Time Magazine front page article dealt with how we're going about our cancer research and focused specifically on trying to tear down the silos between institutions, certainly between different researchers, et cetera, and get everybody sort of on one big macro team. We've got 3 institutions here, so I thought maybe you could speak a little bit to how, if anything's changed in terms of collaborating and seeing that as a mechanism to propel us a little bit faster and perhaps further to finding some answers.
Thanks for your 2 good questions. Dr. Harrison, you want to address the first one on some of the new immunotherapeutic approaches to treating kidney cancer?
Sure, yeah. I mean, I think it's an interesting question because there are some new immunotherapeutic approaches in kidney cancer. Certainly the one that's gained the most press is targeting the PD-1 ligand, or kind of anti-PD-1 or anti-PD-L1 antibodies. So let me kind of explain what that is. So high-dose interleukin-2 is something that kind of revs up the immune system, we think, to try to attack the cancer. And so this is a little bit more specific. It's known that there are certain features of kidney cancer that make the immune system kind of immune to the immune system. And so with these inhibitors, we can kind of release that or block these checkpoints and maybe target the kidney tumors better. I don't know if that's making a lot of sense because it's kind of an inhibition of an inhibition. But at any rate, there are some interesting drugs now in phase 3 studies. There's one compound by BMS. There are others. So there's a study, for example, in patients who've had one line of treatment already with metastatic disease, and it's randomizing them to either everolimus, which is Afinitor, or this new checkpoint inhibitor, and seeing if that will benefit patients. And what's been really interesting is that in the earlier studies, so phase 2 studies in smaller numbers of patients, we've seen some benefits where patients seem to have similar kinds of stable disease or kind of remission-type features. And so that's been very interesting. Now, there are other interesting immunotherapy approaches. There's an autologous vaccine approach that I know Dr. Wood is involved with. This is the so-called ADAPT study. This is taking patients who present with metastatic kidney cancer and who need their kidney tumor taken out. And what it's doing is it's creating a kind of a personalized vaccine from the patient's own kidney tumor and giving that to the patient. We probably beyond this to talk about all the specifics of that right now, but either giving that with sunitinib in the first line or giving sunitinib alone and seeing if that has a benefit. There are some other immunotherapy options, but I think to me those are kind of the most compelling ones, the checkpoint inhibitors, anti-PD-L1 or PD-1, and then the ADAPT study of the autologous vaccine. Roberto may have some others that he's interested in.
These are not FDA approved yet. These are investigational therapies, and you can only get them by participating in a clinical trial, depending on your situation. So some of these trials, the one that Dr. Harrison just mentioned, is for patients who had 2 or 1 prior therapy, and they should not have received prior mTOR inhibitors such as Varicocele or Afinitor. And they get randomized, meaning randomly allocated to receive the experimental therapy, this new immune checkpoint drug, anti-PD-1, versus the mTOR inhibitor everolimus. But there are some phase 1 trials, meaning early stage of development, where they are looking at giving also the anti-PD-1 in combination with other agents for patients who had multiple prior therapies. So you have to check and see, go online or contact your oncologist if your oncologist can find out for you whether you are eligible to participate in some of these trials. We have these trials available for patients who are interested. The other important question is about collaboration. I think this is a very important question. Every institution is different. Obviously, I'll let Dr. Pile speak about what collaborations their institution, which is Roswell Park in Buffalo, New York, they're doing. But at MD Anderson, we are collaborating with other institutions and we're going to submit a SPORE grant application to the National Cancer Institute. And in collaboration with University of North Carolina and Charlotte and Stanford and Baylor, we are putting together a grant to study different aspects of kidney cancer. This is mostly research, but that is translational, meaning we hope that whatever discovery or basic science in the lab, in the laboratory, we find, we bring it to a clinical trial to patients. And so that mechanism, that collaborative mechanism is called SPORE, Specialized Program of Research Excellence. So it's a multi-million-dollar grant. It's competitive, so not every institution or collaboration of multiple institutions will get it, because you're competing not only against other grant applications about kidney cancer, but also about other types of cancer. But that's one way of institutions coming together and trying to advance science, advance research, to try to find better therapies for the patients and hopefully cure. So, Roberto, you want to speak about your institution and what collaborative efforts you have or initiatives?
Well, first of all, I want to commend you for the question and the comments, because I think it's very, speaks about your knowledge and your interest in this. And I think you touched a very important point. There is no way that we're going to advance research or help for patients with kidney cancer unless we work together. And, it's not always easy to get together and to work together. And I think the support mechanism that Tamir has mentioned is one. We don't have many of these grants available right now for kidney cancer, like another disease like breast, prostate, colon, ovarian cancer, as a matter of fact. There's only one right now in the country. So we need more of this team of institutions work together. And hopefully we're going to have more in the future. Depending also the financial support that, as you know, NIH has trouble to get. But one thing I would like to mention is what I think we're missing potentially is a network of institutions to run clinical trials. So to have a kidney cancer clinical trial consortium. And I think at KCI, the Kidney Cancer Association, and it would be a perfect organization to help the community of scientists actually to get things that together. There is a similar effort in other diseases like in pancreatic cancer, prostate cancer, where patient advocate groups have really been pivotal to get the funding to get this network. Because, there are some institutions, some investigators have a clever idea, but they don't have the means to run this clinical trial. So I think they have an infrastructure that, of course, costs a lot of money. But I think if there is resources out there and the right people to make it happen, to me, the SPORE application, these grants, absolutely we need those, but we need to also have an infrastructure to translate this in the clinic. And again, that's something that if this comes from the patients and their family, it will help us to make it happen.
Chris?
Yeah, I'll just make one other point. I think actually one of the greatest collaborations that is ongoing that holds the most promise for kidney cancer specifically, but cancer in general, is it's called the TGCA. It stands for the Cancer Genome Atlas. And basically what this involved were numerous institutions throughout the country sending in specimens to the NCI. We actually, I think, contributed something like 70 kidney cancer specimens. And at the NCI, these specimens are being, basically studied 6 ways from Sunday. Back in the old days, for the Human Genome Project, when they were trying to sequence the human genome, it took them, years and years and years and hundreds of millions of dollars. Now we can sequence a genome in an afternoon and for $1,000. So the technology has really tremendously improved, and actually there is a database online that any of us, even you, could go to and study. And if there was a gene of interest that you thought might be involved in kidney cancer, you could evaluate 500 patients whose tumors have been evaluated to see if it is, and then develop a drug for it. So, there is increased collaboration. There are still challenges with intellectual property and those sorts of issues, but ventures such as the TCGA, I think, hold promise for really curing cancer in our lifetime.
Any other questions from the audience?
We had one from our Twitter followers who are watching online, that it's the sibling of a patient who was treated with high-dose IL-2 and had a partial response and now is on Votrient, and was curious on your thoughts with that therapy.
So this is a patient who had high-dose interleukin-2.
Yes.
and presumably either didn't respond or was intolerant to therapy. Oh, the patient had a partial response and then had progressive disease, and now the patient is receiving Votrient. I think that's an acceptable therapy. There are other alternatives, but I think this is an acceptable therapy outside the context of a clinical trial. Now, if, or when the patient stops responding to this agent, the patient would be a candidate for this anti-PD-1 Dr. Harrison talked about. So that there is that trial. It's in phase 3, and it's looking at patients who had prior immunotherapy with, say, interleukin-2 and received target therapy with agents such as Votrient or Sutent and the like. And they can, in the future, participate in that trial with anti-PD-1 versus everolimus. But that's an appropriate therapy. Okay. Any other questions?
Do a couple more trials.
All right. So this is a 45-year-old lady who presented with a mass in the abdomen. She herself felt actually this mass in her belly. She presented to MD Anderson, had this little bit discomfort, and the blood work was normal, except for that high LDH, which what we discussed earlier is an indicator of high tumor burden. And you could see here on the CAT scan, this huge mass with these are bulky lymph nodes, and this is a huge mass that's clearly not a candidate for laparoscopic surgery. It's a huge mass and maybe involving surrounding structures. So, Dr. Karam?
And
assuming this patient has, we said, there is no metastatic disease to the brain or bone, and this is would you consider looking at this? This is a surgical candidate for a nephrectomy, or would you treat her with systemic therapy? Would you do a biopsy? You were a proponent of doing a biopsy before. What would you do?
I would do a biopsy or just go straight for surgery if this is resectable. I mean, the patient is 45 years old with no medical problems and good performance status and no other metastases. So if it is resectable, after looking at everything else as far as the images, then I would go for that.
Okay, showing you some more of the images. Do you think this is resectable, Dr. Mateen?
Well, resectability is really sometimes an issue of how strongly the surgeon feels and what the patient is willing to go through. But it would require very extensive surgery and, potentially the risk for taking a lot of surrounding tissue out and possibly leaving cancer behind. So
okay.
I think if there's a clinical trial open, we had Chris actually had a neoadjuvant trial for his cases that were locally advanced. Actually, I'm not sure if she would have been eligible for it or not.
Okay.
But this would be a good candidate for that.
On physical examination, when the patient was referred to me, she had a palpable left supraclavicular lymph node. Would that change your approach?
I would biopsy her. This patient has basically a large renal mass with lymph node only disease. I would be worried about papillary renal cell. And with all this, I would probably not do surgery first.
Okay. Dr. Wood, you think this patient...
No, I don't think she's resectable, but can you go back one? On that first picture, you can see there's disease really, right at the... right at the cruce. And I mean, I don't think you could render this patient disease-free with surgery. I think that the magnitude of the surgery would be huge, even for a 45-year-old, and so she'd be significantly debilitated and deconditioned after surgery. And I think it would be a race between her recovering and the cancer taking over, and I think the cancer would win.
We don't want that to happen. So you mentioned here there is a disease above the diaphragm, so another lymph node metastasis. This is small pulmonary nodule, so she has advanced disease with infradiaphragmatic and supradiaphragmatic lymph node metastasis and possibly lung metastasis. So patient was seen by Dr. Wood, and he felt that she has unresectable disease. We did biopsy, as Dr. Karam suggested, and she had this rare variant, metastatic chromophore. Again, this is in among 100 cases of kidney cancer, this would constitute 5%. And in patients who have metastatic disease, this is even less so. Maybe 2% of patients with advanced kidney cancer will have this histological type. Very rare. But luckily, this is a disease, even when it is metastatic, it is slow-moving disease compared to some other tumors that we heard about this morning with, some of the tumors that have sarcomatoid features with them. So this is a disease that even if it's advanced, it behaves a more indolent fashion than some of the other types of kidney cancer. Dr. Pili, so she has metastatic chromophore. You saw the scans. What systemic therapy would you recommend and why?
Well, I would discuss with Dr. Wood whether this patient would still benefit from what we call a palliative nephrectomy if a patient has any symptoms. Because, if even this patient has a lymphoma metastasis, but a chromophore, it tends to be a slow-growing tumor, where even removing the kidney would do any benefit. We're not going to cure her disease, but we're going to just take some of the tumor out. I don't know, because systemically, we know that the drug that we have in non-clear cell carcinoma, and Nizar, you published on this, and chromophore seems to work even less, these drugs in these tumors. So I would discuss but the first question number one, whether or not the tumor from the kidney should come out, and I don't know.
Dr. Harrison, you have an opinion about systemic therapy options?
Yeah, I agree about thinking about debulking and whether that would benefit and having a serious conversation about that. But as far as systemic therapies, I think Dr. Pilley mentioned well that it's not really clear what the right option is. Certainly, clinical trials could be an option. So your clinical trial and our clinical trial at Duke Aspen, that could be a reasonable option because we don't know if the kind of anti-VEGF approach with, say, sunitinib is a better option than, say, everolimus, an mTOR inhibitor. So for me, I would, I guess regardless of what we did locally, I would think about a clinical trial systemically.
But suppose when none's available, what would you recommend?
And then, and this is just my personal bias, I would think about using sunitinib. There is some data with sunitinib. Again, the response rate is probably not as high as with conventional clear cell carcinoma, but there may be some benefit.
Dr. Wood, do you think this is resectable? Or?
I think it says unresectable, if I can read. Yeah. No, I don't. I did not think this. There's a couple issues here. First of all, cytoreductive nephrectomy has never been shown to be beneficial in the setting of non-clear cell histology. So that's, right there, kind of off the ranch. And as I said, looking at those films, I do not think that we would be able to take all of the disease out of her abdomen, but I do think it would be a major, major morbid surgery and, lots of blood loss and prolonged recovery. And I think that it's very likely that the cancer would progress faster than her recovery and she'd never get treatment.
These are just out of curiosity. What was biopsied? Was it the primary tumor or the metastasis?
It was the nose, I think.
Okay.
Yeah, there are some genetic studies suggesting there might be some protein called c-KIT that is overexpressed in other type of tumor like GIST, and it is in the gut, tumor in the guts, and sunitinib does have some c-KIT inhibition, so that would be my first choice. I think what we can say also about the bulking nephrectomy in non-clear cell carcinoma, I totally agree with Dr. Wood. But the question, the problem is these are much rarer disease than clear cell carcinoma. So we don't have the number of patients to be studied to definitely have an answer about. So in my practice, I still go case by case, even non-clear cell carcinoma, whether or not the bulking, if a patient is symptomatic, again, with the idea that we are not going to cure it. But if it can be done safely, and of course I need to rely on the surgical expertise.
So after a discussion with Dr. Wood, and he felt that surgery is not really, the disease is not resectable. We did a biopsy and we proceeded with enrolling her on a clinical trial for patients with non-clear cell, the less common types. There are several of these non-clear cell subtypes. So she got enrolled on that trial, and she received sunitinib at full dose and tolerated it very well, and had a good response actually for about 1 year. And we'll show you some of the. You recalled how big the mass was and how now it is definitely smaller, and the bulky lymph nodes here are definitely smaller, and you could see that there is some plane now around the tumor where the surgeon can go in and resect this with less morbidity and more confidence that you're going to be able to resect the tumor and maybe all the lymph nodes in the abdomen and render her NED without evidence of disease in the abdomen. So she had a good response. Dr. Wood, would you consider now surgery?
Absolutely. I would take her and do a cytoreductive nephrectomy and do an extensive lymph node dissection, resect the nodal disease.
Did the patient have the same response to the lymph nodes?
Yes.
The patient?
She had a response in the left supraclavicular lymph node, as well as the retroperitoneal lymph nodes. The small lung nodules remained stable. And yet, as you see, she had a good response in the primary tumor itself.
Now, these are technical comments, but this is, I think, is potential evidence that sunitinib has a direct anti-tumor effect. Because if you believe a chromophobe is not driven by VHL and is not driven by VEGF, I think probably the sunitinib has a direct anti-tumor effect in this chromophobe patient. And I think
through the c-KIT inhibition.
Maybe or other kinases that we get inhibition, but to me that's compelling. Okay. But it's great response.
Okay, Dr. Karam, Dr. Mateen, you agree with just go ahead, do an open nephrectomy and retroperitoneal lymph node dissection?
Yes.
Okay. Yeah. So patient underwent cytoreductive nephrectomy with resection of all the lymph nodes, and the pathology is on the slides: T3A, N1, M1, chromophobe or renal cell carcinoma with matted nodes, and she had an uneventful post-operative course, was discharged 5 days later, but she was readmitted 16 days after surgery with chylous ascites, and this is a complication that I will ask Dr. Mateen to comment on. Dr. Mateen, would you like to briefly comment on why this happens and how we treat this?
Well, it wasn't my complication, but I'll still speak to it.
Really?
Just kidding. No, whenever we do these extensive removal of lymph nodes, this is one of the known side effects or adverse events that can occur. And basically, it's the lymphatic drainage, and some of it which actually comes from the intestinal area. And so, generally, the good thing with it is that it's treatable. It just takes time sometimes. The first thing is to change the diet to a low-fat or non-fat diet or medium-chain triglyceride. In a lot of my cases, that's usually sufficient. If that doesn't work, you can try a drug, which is really expensive, and it's questionable whether that works. And then ultimately, if none of those things work and they're still draining, you basically restrict any form of diet, and you put the patient on IV nutrition, which obviously is kind of a big deal. But it can be done, and you can send patients home with it eventually. And in most cases, that will suffice. But these can take time to heal. And unfortunately, it's one of the prices that one pays with extensive surgery such as this.
So I think it's important to emphasize that we do not resume systemic therapy with these target agents for at least 4 weeks to allow complete recovery before we start suturant and the like, because of the concern about wound dehiscence. So, and in some instances, we wait 6 weeks after surgery to resume these therapies. So she, after she recovered from this complication, sunitinib was restarted, and it was the dose was reduced, and we gave it at a slightly modified schedule. And despite continuing with therapy, she had disease progression, again in the lymph node chains, in the left supraclavicular area, as well as in the under the diaphragm in the retrocrural space. And she started complaining of some back pain, and MRI of the spine showed that there was a tumor involving T7 vertebra. Dr. Harrison, what would you do now?
Yeah, I might consider thinking about palliative radiotherapy to the T7, and then as far as systemic therapy, again, it's unknown what to do. I might favor a mechanistic switch, meaning switching from a VEGF receptor TKI like sunitinib to some mTOR inhibitor, probably everolimus, which is oral. But I think no one knows what to do here exactly.
Okay.
For sure.
Dr. Pillay, agree? Local therapy to the spine and then systemic therapy?
Yes, radiation and then systemic. And again, I'm compelled. I think the response to sunitinib, at least initially, is pretty compelling. And I wonder whether in this patient is young, you could even try to dose escalate the sunitinib back to 50, or switch into axitinib or pasatinib, the same type of drug, because maybe the 37.5 is not high enough drug. I would probably give. Unfortunately, this patient is not candidate for immunotherapy. We don't know that the new immunotherapies coming, the PD-1, has any role in this more rare disease. But I would probably try to dose escalate sunitinib or switch it to full dose pasatinib or axitinib.
Well, we...
because of the initial response.
Yeah. So this patient participated in the clinical trial, as I mentioned to you, and we had 5 patients with this rare tumor, chromophobe, on the trial, and 2 of the 5 had a dramatic response. She was one of those 2 patients who had a dramatic response. So 2 out of 5, small numbers, but 40%, which is what we would expect of this drug or similar drugs to achieve in patients with the most common type of renal cell carcinoma, the clear cell type. And the median, which is the average progression-free survival, that is how long the disease stayed in partial remission or without progression, was 12.7 months in that study. So in our experience or in our view, this rare subtype of kidney cancer that belongs to this non-clear cell group does respond in a similar or comparable way to the more common type clear cell to agents such as the one that she received.
I think there are some retrospective analysis. My understanding was chromophobe tend to respond even less than probably to TKIs, but there's something going on in this patient maybe. But I think even send it as a case report, because I think it may induce physician to still try sunitinib. We're going to know more about the ongoing clinical trial, but probably you're not going to have a lot of
there are 2 trials looking at the same group of non-clear cell, the rare subtypes. As we mentioned earlier, the ASPEN trial led by Duke and the ESPN trial led by MD Anderson, and basically treating those patients with sunitinib versus everolimus. So we elected to treat her with everolimus, 10 milligram a day. She had stereotactic radiosurgery to the T7 metastasis, and her back pain resolved. She's still receiving everolimus now past 1 year without any significant toxicity. She is still maintaining active lifestyle and working. But 18 months later, while she's still on therapy with everolimus and her disease is under control, she showed up in Dr. Wood's clinic. He was happy to see her, but But she said, no, it's not for me this time, it's for my husband. So she brought her husband, and her husband was diagnosed with kidney cancer. Mass will show you the scans. He had a left renal mass, a mass in his left kidney, and on chest x-ray and subsequent CAT scan of the chest, he has metastatic disease to the lymph nodes in the chest. The rest of his workup was negative, and the blood work was normal. Now, his review of system is negative, except that he has hyperlipidemia and hypertension. And here is the mass in the left kidney. And then here you can see the lymph nodes. Dr. Karam, what would you recommend?
These are the only sites of metastatic
Yeah, his
disease?
performance status is basically 0.
Again, I would discuss the option, but to give you a brief answer, I would go for cytoreductive nephrectomy on the left side.
Is there a possibility you could do a partial here? Or?
There is a possibility, but given that the patient will start targeted therapy probably after surgery, I would try to do the operation with the least possible side effects. And again, that doing partial nephrectomy in the setting of metastatic disease, it's been reported in at least 3 studies, very small studies, it's doable. But typically, these have been patients who have 1 kidney or 1 functioning kidney. So if the mass is small, I would consider it, but I don't see a compelling reason to do it in this patient.
So you would do a laparoscopic robot-assisted left radical nephrectomy?
Just a laparoscopic left radical nephrectomy.
Okay. All right, Dr. Mati?
Yeah, I agree.
Okay, you agree? All right.
Yeah.
The other thing I would tell him to do is put his house up for sale and move as far away from there as possible.
All right, so the patient underwent a laparoscopic cytoreductive nephrectomy, and the pathology was consistent with T3A and 0M1 clear cell renal cell carcinoma. So different subtype of cancer than his wife, who had chromophobe, if you recall. He had metastasis to the resected left adrenal gland. Dr. Pile, what would you recommend now?
If it's a candidate for IL-2, I would offer if it was in Buffalo, I would offer the clinical trial that we have.
Okay, Dr. Harrison?
Yeah, I mean, I think he's young. Looks like he's a candidate. I would offer him high-dose interleukin-2.
Okay, all right. So we did offer him that, but he elected to be treated with target therapy, and he is enrolled on the STAR trial and was randomized to first-line therapy with everolimus. So him and his wife are taking the same medication, both tolerating it very well, and he's shown already tumor regression response now 6 months since he was enrolled on the trial. We'll do one more case, and then I think we can wrap it up and open it up for questions again. This is the last case we're going to discuss. 62-year-old male with blood in the urine, diabetes and high blood pressure, had appendectomy and knee surgery, examination unremarkable, no tobacco or alcohol use, and imaging studies showed a locally advanced right renal mass and spots in both lungs, so pulmonary metastasis. Here is the mass. And then here are the pulmonary nodules, here and here, here. So at least several in both lungs. In addition, he has anemia, so low hemoglobin. The brain and bone were negative. Biopsy of this lung, one of the lung lesions, confirmed the diagnosis of metastatic clear cell renal cell carcinoma. So I think in the case of time, we'll just move on quickly here. So what he has is anemia, and he's presenting with advanced disease with primary tumor in place, so he has 2 risk factors. So he falls in the category of intermediate risk. So he has this here by the Memorial risk classification, as well as the more modern classification that has been developed in the era of target therapy. He has what we refer to as intermediate risk disease. So, Dr. Mateen, would you offer this patient cytoreductive nephrectomy up front?
Yeah.
Dr. Karam, different opinion?
No, yes, I would still do the surgery.
Okay, Dr. Wood, agree. Okay. My medical oncologist colleagues? Surgery, okay. So he undergoes surgery, and it's uneventful. Now, what systemic therapy would you consider for this patient? Assuming he recovered completely, and post-operatively has mild anemia, but his performance status is good.
I would consider high-dose IL-2 first, assuming that it was available at my institution, because, again, this is a young guy, low-volume, lung-only metastases. I think he'd be a great candidate for high-dose IL-2. Barring that, I think that the best evidence would suggest that he should start on either sunitinib or pazopanib, either one.
Dr. Pile?
We already heard from the medical oncologist, so I don't need to add anything. Exactly what I would say.
Okay. Dr. Harrison?
I agree.
So we want to all be aggressive and treat him with high-dose interleukin-2?
I agree with our three
Or
medical
offer it to him,
oncology
at
colleagues.
least. Offer it to him. Dr. Mateen?
Ditto.
Okay. All right, we can stop here, and we have a few minutes to ask any questions, make any comments.
And then Carrie wanted to say something. Brian, could you get Carrie in here? Any other questions related to what we talked about, or any other questions outside of what we talked about? Is there anything that we didn't cover that you have questions about? Please don't hesitate to ask. So what do we think about the format? Yeah, go ahead.
Quick, I guess it'll be kind of outside of what we've discussed.
Mm-hmm.
How concerned should we be as patients of the full implementation of the Affordable Care Act?
Very.
Any comments are welcome.
Depends on whether you're going to continue having insurance or not.
I mean, I think there's real concern.
Yeah, I mean, their concern goes both ways, and I'm not sure how much we want to get into this, but, the problem is, whether you realize it or not, all of you who are here probably have the luxury of being able to afford insurance. But the truth, the ugly truth about medical care here is that there's two tiers. And there's a huge population of patients who get their care through the emergency room. And so, to try to address that and at the same time contain costs, which everybody agrees is out of control, some of which has contributed, I think, my personal opinion is that there's a preponderance of greed across the entire medical spectrum. And it starts with patients and doctors and insurance companies and politicians and drug companies. Patients want every test done sometimes. Doctors get insecure, so we order everything. So anyway, it's across the board, and nobody wants to give up anything. And so all of that adds to the issue of rising costs in care. But the ugly truth, and I don't know the solution, but the ugly truth about medical care here, as good as it is that there are patients who are dying from inability to afford care and from preventable conditions.
Do y'all see the possibility of the cost of, these new drugs and where we've come is wonderful and it's great. It's benefited all of us. But it comes at a very high cost, again, as we know. Do we see that being hampered as far as these future? We talking about things, we always talking about things upcoming. Are those things in jeopardy? The research dollars, is that a hindrance? Is this going to be a hindrance on?
Yeah, I think all those issues are very real. The cost of these agents that have revolutionized the outcome for patients is astronomical. And, I think with Obamacare being instituted, we're going to have to make choices, and those choices are going to be very difficult ones, and I think that we're going to have limited access to these agents. I think that, with this comparative effectiveness, that some of these agents are going to go by the wayside because they're not better, or they're not, even though they're different, they're just not better, so they're not going to be used. And I think that, it's going to be a real challenge. I think that it's sort of a double-edged sword. On the one hand, we have these great drugs that can potentially cure cancer, but we really can't afford to use them.
We're already seeing, as I mentioned earlier this morning, where we're getting really denials from insurance companies. So it's going to get worse with insurance companies, a clerk or a bureaucrat on the other side of the line, the telephone line, basically dictating to us what tests we order and what treatments to give. And it may get worse. I think, we have to really be prepared for this, where we may not be able to give the successive, like you heard, we treat people sequentially, but we may get to a point where, like in Europe or Asia, where some of these drugs, we have all the drugs available to us. And in Europe, they may have only 2 or 3, and they may not be able to go back using what worked for the patient in the first line for, say, 2-3 years. They cannot go back to that drug again because they say you can use it only once. So it's going to impact, there's no question, it's going to impact our ability to order tests and treat the way we think is best for the patient.
And I think, the issue is that it's hard to have a frank, what we want to really have is a good discussion, and patients need to get involved to some degree, and the whole population, because everybody's going to have to give up something, and nobody wants to give up anything. And on top of that, you have this chaos created by extremes in both political situations, where there's basically a lot of unsupported claims being made for the sake of gaining political ground. And we all stand to lose a lot from that. And, when I mean everybody has to give up something, in some ways it may mean physicians having to accept becoming middle-class people like they were back in the 50s and 60s. It may mean you all having to accept fewer choices and maybe not having the option of paying several thousands of dollars for an extra 2 months of life. That sounds harsh, and I don't mean it to be harsh, but that's where that discussion, you need to tell us, is that worth it from a societal perspective? Listen, my family, yeah, I'm going to say, if it's my family, I'm going to say, hell yeah. But really, if we can distance ourselves and look at that from a global perspective, that's the kind of population-level decisions that, these are things people talk about. But, it's hard to have that discussion because there's these incredible extremes, political extremes, that drown out where most of us stand, which is somewhere near the center. I find that to be a real shame right now.
Well, now that Dr. Mateen has totally bummed us all out. Carrie, why don't you come up and talk a bit about the Kidney Cancer Association? Oh, is there another question?
Aren't you so glad you asked that question?
Sorry, go ahead. Sorry about that.
No, just that I want to know if there is any evidence that this is hereditary. Could it go down to the kids or down in the line grandkids?
There are genetic syndromes that are associated with kidney cancer. They're rare. Sporadic is much more common. We typically don't worry about it unless there are 2 first-degree relatives that have kidney cancer. We also worry about it in patients who present at a very young age with kidney cancer. Those are sort of warning signs to us that this could be a genetic syndrome. But the vast majority of cases are sporadic, not inherited.
But it is tough. There is probably some familial predispositions. We saw a case earlier where there was 3, family members, and of course you think von Hippel-Lindau. But, a lot of times the tough thing also is that the family could have had the same exposure to product, whatever it was in the environment or diet that put them all at risk. And that's one of the hard things. We have a researcher here who actually collaborates with us, and she's a molecular epidemiologist. And Chris, I don't remember the exact finding from that study, but if you remember, she was actually able to show that if you have kidney cancer in the family, it does predispose to the rest of the family, being at a higher risk for developing it.
Yeah, the risk is like five-fold increased risk.
Yeah, so not something small, but so I think it points out the fact that there's probably some genetic predispositions that some people have that we still don't know exactly what they are. But then when you add to that something in the environment we're exposed to, I think that means I need to stop talking.
No, I just wanted to, Nancy asked the question earlier to me during the break, but there are some red flags or some, factors or variables that when we see in a patient, that basically rings the bell. And for further evaluation to study if there is really an inherited syndrome. And these are three. First, having kidney cancer at a young age. Secondly, having tumors in both kidneys. And thirdly, if there are multiple tumors in the kidney or in both kidneys. So if you have that, a family history, young age, both kidney tumors, tumors in both kidneys, multiple, those four things, then one would then need to consider one of these inherited syndromes. And, beyond the VHL disease and the papillary type 1 inherited syndrome and the hereditary leiomyoma, renal cell carcinoma syndrome, papillary type 2, there is a recent syndrome that has been BAP1, characterized by BAP1 mutation. So I think that there are those things that we may discover more families, more inherited syndromes. But one would not think about it or worry about it if there is no family history at all, and it's an occurrence at 60 years of age or older, and it's just typically unilateral, one lesion in the kidney.
Good. All right. So I just want to talk briefly, just a little bit about the Kidney Cancer Association for those of you who are not familiar with the organization. Our organization was founded in 1990 by a kidney cancer patient. At that time, his diagnosis was probably very different compared to when many of you are diagnosed. There were no treatments. There was no organization for him to turn to find any kind of information. And so his physician challenged him with doing something about it. And Gene did, and he created the Kidney Cancer Association. At the time, the key things were just getting some information out there. He had information on the internet before people really knew what that was. Those were the kind of the key issues. Interestingly, that some of the questions being talked about before I got up here, talking about the economy, talking about healthcare, and so many changes. But that's something that our organization is very focused on, is to continue to educate patients, to help advocate on behalf of patients all over the world, and continue to help fund and promote research. And those three areas are the core of our mission, and they always have been. Your feedback coming to these meetings is helpful to us as we move forward and face these different challenges. We're fortunate to have great advisors, such as many of those you see sitting up here on our medical steering committee. We have a nurse advisory board with nurses from all over the world. And we have a wonderful board of directors who, sit down and discuss these same issues that you're bringing up today. So I encourage you to continue to provide us with, with feedback, with your thoughts. I wanted to put up, instead of, just doing some slides with some screenshots of our website, just to pull up the Kidney Cancer Association website for you, for those of you who haven't had an opportunity to visit it. This is the best place for you to come if you have questions. Normally, we have on, a weekly basis, anytime from 5 or 6 in the morning till late at night. One of us is always online, and if you go to the website, what you'll normally get is a pop-up that is a live chat. So somebody, myself, our CEO, or another one of our staff members is available to chat with you one-on-one instantly to help you navigate the website, provide you with other resources, and help you to answer your questions. Just a few key things to point out. Right here in this box, I'm not going to play it because I'm afraid I'll start hearing myself talk. This is where we have the live webcast going now. But normally there'll be weekly news up there. You'll be able to get to our YouTube channel from this box. So following the meeting, today's morning and afternoon sessions, it's in 2 parts, will be available. You can see the recorded version, and then be able to see past meetings, some of our medical symposia. And we do try to do probably every week or every other week something new that's in the news about kidney cancer, as both a video and something written for our patients. Here you can get, I know some of you had asked me earlier today, we had a few copies of our publication, We Have Kidney Cancer, that is reviewed every year by our nurse advisory board. Oh, there is the pop-up. So here's where you can order a hard copy of our publication, We Have Kidney Cancer, or the companion piece, Survivor Stories, which features about a dozen patients and caregivers telling their story of kidney cancer. You can also get a free e-reader of these or download the PDF. So they're all available from that spot on our homepage. And then the other key thing, if you're looking for more opportunities to attend meetings like this, you can go to our support group meetings here and find a list of all meetings that we have, or if there's not one in your area, we can help you to get one started. Another area kind of talking about this access to therapies and being able to cover the cost of your disease. We work with a number of organizations that will help provide financial assistance for you, help you to start fundraisers if your family and friends want to help you to fund therapies or other costs that you might have associated with the disease. You can find that information from this page. We've also partnered this year with an organization called Lots of Helping Hands, and what this organization will do is help you to create your own community. So if you're looking for people to give you rides to the hospital, to help cook meals, babysit your children, come and clean your house, they'll let you set up what you need and let people volunteer at different days of the week, different times of the month. You can update them with how you're doing. So it's just a new site that we've been testing this year, and encourage you, if that's something that you might find useful, to to set up a community for with your friends and family. And then finally, too, in terms of looking for support and communicating with other patients and families, any of our social networking sites here, our Facebook has over 65,000 members now from all over the world. Many of you may already be on there and communicating with one another. Again, that's a great forum for you to provide us with feedback, with your concerns and questions that you might have. And same with our Twitter account as well. We're on there pretty regularly. And just one final area I want to point out to you, too, kind of based on some of the information from today, is the drug information sheets here that's on the side menu. You probably learned a lot about some of the new therapies that are approved for kidney cancer. And our nurses have done a wonderful job over the last few months of putting these into 1 to 2 page forms. Each drug is in the same format, so you kind of can look and see what the average dosing is, what some of the side effects are, and then kind of how to manage some of these side effects. And the second phase of this, hopefully sometime by the end of this month, we should have videos that'll be companion pieces to these that the nurses have done to talk a little bit more about what these side effects are and how you can manage those. So I would encourage you to spend some time on the website. And again, as I mentioned, we're almost always on there with a live chat. So if you're on the site and can't find something, feel free to say hello and we'll try to help you out. So are there any questions for me or anybody else on the panel? All right. Well, thank you to Dr. Wood and to all the rest of our panelists and to our sponsors, Genentech and Pfizer. And thank you all for coming.